what we're going to do today, he's going to talk about simulation, and then questions will be on the chat, and after that he will continue the discussion from 6:30 to 7, and then after the discussion, if you have any questions, please write it in the chat and I will raise it up to him, and at the end of the discussion today. We will have another session soon. We will announce it at the end of the webinar. And regarding if you need any information of COVID-19, we launch something new in our website. You will find it in the library, COVID-19 update, and it contain simulation update, topics update, anything regarding COVID-19. And please be safe and take care of yourself and the precautions. Inshallah, everybody will enjoy this lecture with Dr. Boker. Currently, we have 33 attendees. Total attendees which they register is 400 plus 74. Hopefully, everybody will be able to join. Our web is able to content. Hopefully, لا انت اضغط على اللينك اللي ارسلت لك، هو ما يحتاج تدخل على هذه بيرسونال اي دي واللينك. اخش على اخر حاجه يعني. ايوه في يجيك لينك قبل الجدول، شفته؟
Hello, السلام
عليكم.
I will share my screen.
Yes, لو سمحت. So we thank you, Dr. Abdulaziz, for being the first participant for us. Dr. Abdulaziz Boker, who was the head of our society, and
ممكن بس can we wait حتى ساعة ونص، لسه باقي دقيقتين.
إيه. Currently we have 41 participants. يمكن زاد العدد ثواني. Now 51.
Another 2 minutes and then we'll get started.
Good afternoon, everyone. This is Dr. Amani. I'm the one who's going to be moderating this session. And thank you for joining us in our webinar. Today, our webinar is we're going to talk about COVID-19, and we appreciate if you keep the question at the end of the lecture. So it's going to be easy for Dr. Abdulaziz to go through all the point that he wants to cover it and the objective. If you have any questions or anything, you can write it in the chat and I will read it out loud for everybody and Dr. Abdulaziz can answer it. So please welcome with me Dr. Abdulaziz Boker. Prof. Abdulaziz Boker is anesthesia consultant in King Abdulaziz Jeddah Hospital, University Hospital. And he is our society chairperson or president. And definitely Dr. Abdulaziz is a well-known figure in the simulation society. So thank you, Dr. Abdulaziz, for doing this webinar free for everybody. And please share your screen with us.
Bismillah ar-Rahman ar-Rahim, alhamdulillah, salatu salam ala Rasulillah. I hope this is clear for everybody. First of all, I would like to welcome you all for this webinar, our series of webinars that will be covering the preparation for the COVID pandemic. I appreciate the help of the Society, Scientific Committee, and the Media Committee chaired by Dr. Marshad and Dr. Amani for putting all the arrangement for this. As you know, the Saudi Society for Simulation in Healthcare deal with preparation and using simulation to advance members and community alike and include physicians, nurses, allied health sciences, personnel, everybody who works at the field of simulation as a tool for education in healthcare. Also in this session, I'm presenting a lot of the work presented by King Abdulaziz University's Skill and Simulation Center. They're contributing most of the material that will be presented. So today I'll be talking about briefly on the coming 20 minutes or so, and then we leave time for questions. 1, 2, 3, go. How to use simulation for team training at crisis mode. And I use the color code red, orange, and go to indicate the steps that you need to keep in mind in terms of preparation and also conducting simulation activities. So those are the objectives that already shared with you. How to develop effective training exercise at own place, how to make use of conducting ready material based on your local resources. How can you help your team to grow in this time? Probably your team has to be grown big time. How to debrief. After simulation is done, you have the scenario. How to debrief. What are the things that you could use out of this webinar to practically debrief your team and also provide you means to get many international and local resources for your immediate use and or modification. So, as I said, number 1, safety for all. The other question, number 2, is when, why, and where. And number 3, doing it is how you will do it in real life based on the experience that we had with the previous corona epidemic as well as the current corona epidemic. So first of all, safety for all. We always talk in simulation that simulation is used for safety of the patients. Today, like aviation, simulation training is important to protect ourselves, our family, team, and also our hospital, because everybody will benefit from improved care and also safety of the practitioners. We've heard from China, from Italy, from many other countries, how many people can be infected. Using simulation to train people will prevent this from happening. So this is a key important aspect. Also, when we do simulation, especially in real places, other patients might see it. So we need to have that in mind to safeguard against any harm to other patients by using simulation. And also a key aspect for simulation safety is psychological safety for participants. And the differences between feedback and debriefing we will highlight in the coming few slides. These are the rules to make sure that your simulation participants are safe psychologically and they could use simulation. These simulation rules apply for all simulation activities. First, everybody who participate have to agree on confidentiality of the scenario and performance. So whatever happened in simulation will stay in simulation. Nothing will be transferred to reports or reporting. Fiction contract, everybody know in simulation, sometimes we don't use real equipment. We don't have patients. We have actors. We want to make sure that everybody treat the situation like real, and we have to consent. This is very important slide to keep out of this presentation because you have to tell this to every participant. Also, as a participant and as a moderator and instructor in simulation, you need to remind yourself and every participant in the course that they have to maintain basic assumption that everybody wants to do a good thing and everybody is competent. We will expose people during simulation to their weakest point. We want them to feel safe, that no judgment will be made against them. So confidentiality, fiction contract, they have to treat situation like real, and basic assumption, everybody is competent and everybody has good intention to do a good care for himself and for the team. When is it safe to do simulation? I think it's now, during and after the peak of cases. We need to build teams. Why? We want to increase the readiness of the individuals, teams, and institution. Some people in the coming few days will work in some other areas. So we need it for retraining, increase confidence. People will be scared. And also to test the system. Do people have the right equipment, or we need to bring them right equipment in special form or way? And also to train people in teamwork and to work with challenges and shortage. We know in many parts of the world, they're running out of equipment. So what to do, what we call in education as if or what if. So what happened if the person did not hear you? How you could send a message, maybe have a card, develop something that you could use in real life. Where to do the simulation? Do you do it in the simulation center, or you do it in the clinical areas, in situ or in vivo? So of course you have to do it everywhere you can. We better use it in temporary center if you have a dedicated center, or clinical areas away from the patients, or near the patient area, or in dedicated ICU. And of course the cost and how real is this, and the setup will be variable according to the different areas. Of course, the content, the rationale, uses, pros and cons, and the variation, and how to optimize it, and how to summarize it. This is ongoing process. So you start with a small group, then you test the scenario, then you tried it again and tried it again, and move it from one place to another. This is an example about insight to simulation.
Last week I gave a fire safety talk, and nobody paid any attention. It's my own fault for using PowerPoint. PowerPoint is boring. People learn in lots of different ways, but experience is the best teacher. Today, smoking is going to save lives.
Oh my God! Oh my God!
Fire! Oh, fire! Oh my goodness! What's the procedure? What do we do, people?
Both are dead.
Oh, how did that happen? Oh my God! Okay, it's happening. Everybody stay calm. What's the procedure, everyone? What's the procedure?
Stay calm!
Wait. Everybody calm down! No! Anyone? 911.
So you could, of course, I don't recommend to do that in situ, but you need to prepare your staff. You could use mannequin, you could use simulated patients, you could use part task, like, or different types. You could use different type of level of simulation. You could have it scheduled or unscheduled, promptu, in terms of you need to tell the important people, like the head nurse, the doctor, the in charge, and you want to have people participate in in-situ simulation after they complete the basic training. So if you have the time, you train them, and then the second level you go to in-situ. Sometimes you could use in-situ simulation for system assessment. What, like a need or need assessment study, and then find what are the weaknesses that the system have, or individuals, or the areas for improvement, and then you could plan your training. So you could either do it in the start, you could do it at the middle, and also you have to do it at the end to make sure that everybody will follow the procedures that's set up by your hospital according to your standards. Of course, there are a lot of theories supporting using simulation because it's based on experiential learning theory and from also system engineering, because when we work in crisis like the one that we have now or we will have, we need to prepare persons, tools, technology, task, physician, environment, organization, and the simulation could test and redesign the engineering. For example, many places now, they will have special kit to be delivered for COVID positive patient or suspect. So the simulation could help you design things that you need in real life. Also, you need to integrate crisis management, CRM, crisis management procedures, because safety comes with crisis management, and this is always coming from simulation in aviation. Crew resource management or crisis resource management comes from, because we know it's not only having the technical skills, also how the team dynamic, and this is the term that you will see a lot in all scenarios that we will share with you in terms of, because crisis management, we need to have good technical skills, how to do the PPE training, personal protective equipment training, and also how to have crisis management behaviors and teamwork. We need to focus on both of them. The crisis management have two major components: cognitive component, knowing the environment, anticipation and planning, use all available information, prevent, manage fixation error, and using cognitive aids like cards and so forth. Also, CRM include effective team management components like leadership, followership, communication, how to distribute the workload, as well as calling for help appropriately and early on. How much we focus on technical and non-technical skills? We always say 60% to non-technical skills or CRM principles, 40% during high fidelity simulation or the in-situ on technical skills. But both of them are very important. But the focus, we need to fix or spend time talking to the team and individual about these two. Of course, you could have the scenarios with the equipments. You could have regular courses. Usually it lasts for 10 minutes or 20 minutes. For example, training the airway team how to intubate COVID patients. You could have it stat, like elective, or crash, emergency cases. We advocate to have doctor, nurses, patients as role, and also family members. Sometimes the positive person is the husband of the wife, so he has also to be in the equation, especially with the high infection rate with this virus. This is how simulation room, once you have the scenario, you could play it like this. People do the scenario, you watch it, record it, and then debrief it. Of course, these usually have multiple level of difficulty and increasing. They're really challenges, and that's what meant by making crisis. If this is done right, you cannot, and everybody treat the situation like real, you cannot differentiate simulation scenario from real life, and that gives a lot of face validity for this technique. After you announce, like what you saw in the video, you have to announce simulation finish. You need to tell people to doff, for example, using appropriate technique, and observe them during doffing, and then come sit down and do the debriefing. This resource I built using simulation for simulation-based training for Ebola and Corona in the first episode 2016. This work has been done by Dr. Jamil Abul-Ainain and Dr. Maha Lawi. It's an excellent review. It's available free on PubMed, published in 2018. It has show you the whole system, how to train trainers, and how can you use the trainer to train large number, like 400, 500 in a week or two. It's a very important work that describes all the processes that I talked about. Also, you could go to the Saudi Society of Simulation in Healthcare. It will give you a link to the International Society of Healthcare, in which you could have, as here, all the helpful resources. I will share some of that here, but if you go to the website, you will have the videos, the scenarios, all the ideas, and these things are updated every day. This is an example of a scenario from UIC. I thanks Dr. Christine Park for sharing this, and this is available for members. So this is a typical scenario. I could show you more information. So this scenario has 8 pages. It has everything you have to run a scenario: objectives, what's everybody role, how to debrief it, what equipment, what moulage. All the information you need to run the scenario is already written in this material. And you could use this tonight, tomorrow, to train your people and then expand the training. And this is example of what we do, skill training at the skill center, and then take this from the skill center and take it to ER, or have the endoscopy people, radiology people. You see how they behave and how they react, and then the same thing we've done in our operating room, labor floor, and then you have either sit down or debrief people on the whole process using the techniques of debriefing. So we took these scenarios, we tested it, we ran it 1 time, 2 times, it's okay, we try it, and then we use it with the team and see what are the problems and how they could, what are the good things they did and what the things that they could improve, and I'll be talking about debriefing. Again, experiential learning model is very important. So this model in which we ask people to reflect and think what to do. Of course, when most of the learning happens for the team is in the debriefing. So we have to give them safety, everybody talk, and usually those are the components of debriefing. Communication, you ask everybody what happened. You have to ask them about emotions and the time, how long. Usually we take 30 minutes to debrief 10 minutes scenario into 30 minutes. You need to talk about their emotions. Were they scared? Were they confident? Were they happy about what happened? How can they improve? And what are the systems they will use for the next time? One simple model of this debriefing, this is a simple model, 3 steps, general description about the feeling and the procedure. Then we have to have everybody talking. Then we ask them, what are the things that they did well? What went well? And that's very important to talk about things that went well, because you want people to continue doing them. And then you move to things to improve. Okay, what did you see and what did you do and how you could improve it? And this is to help people reflect, think. So they have experience, reflection, have concepts, and then they have experimentation. And you always want them to go through this cycle and again. It's all about reflection and debriefing. You want them to improve reflection, how they think during the crisis. And you do this by helping them reflecting on action. So what I was thinking at that time, and always, this is what we always go. So this is simulation. We ask them at this time, what were you thinking and why you were thinking that way, and how can you do this better in the future? So this is what we call to reflect on action, to improve future reflection in action. Now they are thinking what's going on in their heads. You want them to think about what they're thinking to improve their future thinking. So this is what we call reflection in action, to be improved by reflection on action. What did they do and how they could improve it. And this is what we call deliberate practice. The more people do this in simulation, the more they have chance to do this one or more time, the more they could have more improvement with time. And this is, again, we do it in skill center, we do it in the clinical, and these are few things when we use in simulation. We always encourage non-judgmental approach to debriefing. So why you did not do this? I know it's wrong, or why you do this wrong, or you make a judgment about what. Instead, we always go for debriefing with good judgment. So I saw you doing this. What were you thinking? Do you want extra help? Or why did you shout at the nurse? Those are things that usually in feedback, we do it. But in simulation, it's better you describe what you saw, and then you ask the participant, what were you thinking? Or you were screaming at the respiratory therapist. What was going through your mind? How can you do this the next time? So we always ask participants to reflect and to say what they will do in the future, and then sum up and come up with plans for the future improvement. For more resources, I advise you to go to the website. I will share with you the society website. Also, you go to our Twitter account, and if you're interested, you could sign up for the membership, and then you could have constant update for all the resources. So just to summarize, the objective of this talk was to develop effective team training exercise at your own place, share with you some of the experience, how we plan and conducted simulation-based experience based on your local resources. Whatever you have in your institution, you could always start from there, use international resources, and have the exercise of debriefing members, and then debrief the debriefers for improve in the future. And as I said, the society, the International Society of Simulation in Healthcare, many international societies, we are sharing a lot of resources for you for immediate use in your institution. This is the website for the society. I'll be more than happy to take your questions and answer. Thank you very much.
Thank you, Dr. Abdulaziz. There were a couple of questions during the discussion. One of them, our COVID in situ, very informative for the team in the hospital. Can we do it multidisciplinary team?
That's a very good, important question, because we have, we always recommend to have the people who will work in real life to be trained together. It is best interest for everybody to work together during simulation, because that will improve their performance as a team. As we said, it is a teamwork. Every functioning team nowadays need to have a very strong members: the nurse, the respiratory therapist, the technician, the cleaner, the doctors. Everybody is as equally important in the team, and we need to focus on all of them. So including all of them is very important.
There is another question on the Twitter. They were saying if it's recommended to do multidisciplinary team, so how can we involve all parties? Do we communicate with the leadership, or like we can communicate with the stakeholders?
I think all of the above. You could do this within your own department. We are lucky in our institution. We have a very good connection and direction and support from our administration. And I'm sure if you show good example, you will have the same support. It is very important to have important leaders, head nurses, department chairman, your dean, hospital director, quality department. This is all teamwork to plan this very well. So yes, you could do simulation yourself to protect yourself, protect your team. But when it comes to real life, the next step or the important step is to have everybody come together and work together in simulation, because in real life, all of us will work together.
Okay, thank you for sharing this. There is another question. What type of research we can conduct through the simulation, especially now they're not like the fund with the Ministry of Health announced it?
A lot of opportunities for research, and I think there will be few more seminars like this or webinars like this. A lot of ideas. Anything that you do, have a good documentation for the need assessment, for how you conduct the material, collect feedback, and also observe what happened. For example, if you have a form for your insight to simulation, compare form number 1 to form number 2, 3, 4, 5, 6. If you do this over 6 months or over 2 weeks, you could see the improvement, and you could later publish this. So I think there are a lot of opportunities for research and improve patient outcome. And the most important, as I said, it's also our safety, our family safety, not to take infections, for example, psychological safety for everybody, and of course the patient, the institution safety could be reinforced with effective simulation training at all levels. You could show people videos, but can people apply this on their own? Can they talk with the mask? Can they communicate with when the mask is on?
Thank you for those ideas. There is another question from Bara. So he's saying that, as you know, Prof, that WhatsApp group share ideas internationally. Would so the society would do the same thing similar to local, so that we don't have to invent a wheel and do another research, which is other areas doing it? So I think what Bara is asking, can we do a research group so we can share the ideas, and so we can collaborate and do the same work, like rather than everybody's doing the work separately?
Two things. I thank all of you, of course, for being here. A lively discussion. I could see the questions coming up. The main priority at this time is that we establish the network between all international societies, and we are sharing the resources. And this is one of the important aspects of this seminar, that you have already a lot of international material ready to use. So you don't need to spend a lot of time in thinking. You could customize all these resources, and this is shared. I think the idea of international research on this is fantastic, and we need to consider this and continue to work, because it is the way to go, because I think this will be in for a long time, and different places have different experiences. Research definitely is the way to go to improve the benefits out of simulation to everybody involved.
There's another question saying, like, if we're doing in situ simulation, how can we do fiction contract? How to make sure that everybody is safe, although it's in situ and it's sudden scenario?
It's a very important question. There are a lot of things you need to consider. First of all, if you use drugs or equipment, you need to make sure that there is a very clear label that these are not real. This is for simulation. So to differentiate equipment from simulation and equipment for patient care, if you use it in situ. Also, the fiction contract, this comes with time. The more, and that's what I say, when you train people in a simulation center or a small group or in a training area, you take them through the concept of fiction contract. With time, this more people we will get into they know what is this, but having key people involved and then taking, I don't recommend the first thing you do is inside to simulation. That's why I say you need to mix and match videos, some lectures, hand-on, and isolated areas or corners or dedicated space or simulation center if you have one, and then you take this to clinical areas. You cannot, it will be helping preparing people, but there are a lot of research saying that even the people who did not attend the first simulation will hear from others, and the future performance of other team, maybe they did not come to the training, their performance will be better. And that's what we want to do. We don't want to trick people. We want people to do the good things. And combining off-site and on-site simulation is the best combination from our experience.
Thank you for sharing your experience. There is a question that if we're running simulation sessions, and how can we implement for the COVID-19 and other scenarios, respiratory will be a good tools to use simulation for it. But how can we use simulation to implement other objectives? So I think the question is, how can we use simulation also to discuss other points of objective rather than respiratory or procedures, like other communication or other points?
That's a very important question, because if we just stick to the technical skills, only how to do the intubation or how to don and doff, that's very important. That's technical, but also how people communicate, because we know this is very stressful situation for everybody, for the patients, for the relatives, for the system, and for us, the healthcare providers, for all the team members. This is very tense time. The more simulation they do, we need to let them talk about their feelings. From our limited experience on this, but it's growing, and we've been using it for 6-7 years. People at the start, they say, we are scared. We still feel the tension. With time, the more they do it, the more they are more confident, the more they get into even dealing with stress in better way. And that's what we want. We want to, this is actually, some of this is fun. So if people laugh, it's okay to laugh, because sometimes when we're scared, we laugh. That's okay during training. So we need to make it functional, fun, learning, effective experience. How you would do the next time better. And I think focusing on non-cognitive skills, what we call crisis resource management, behaviors, leadership, communication. I saw you talking. Can we use some non-verbal movements, for example, or how can we improve this the next time? Somebody might say, okay, we need cue cards. Sometime if we have printed material, I could point, bring me suction, or give me more oxygen. So the more time you do with a team, you could come with solutions that will help people in real life.
Last two questions. So the first one is, can the society help the people and the employee to have their ideas to invent equipment to help human in medical field? And if yes, how can we do this?
Come again?
So can the society help the employee or the healthcare provider to invent equipment, and this equipment will help the medical field? It's like invention.
You know, in the last 3 days, we came up, or I came across 5 or 6 different inventions. One I shared with the WhatsApp group yesterday. Simple solution to connect one ventilator to 8 people. So today there's acrylic boxes. I know one group is doing it in Jeddah today, and one group doing it in the States. It's, I think, somewhere from Australia. I think having these ideas and trying them out, because not every hospital, not every town, even in the same town, every institution have different issues. Some places will run out of BBE equipment. You need to develop others. For example, today we developed, we ran out of N95 masks. Today we learned a new way of making paper 95 masks. So instead of wasting the 95 masks, today we start making them papers, and we'll publish this experience, and we will invent this for other training center, and we share. So there is a lot of opportunity. This is a crisis, and during crisis, there is also some good ideas that will come, and the society is very supportive to spread, to test, to research these all great ideas.
Last question. Can we use those articles and the guidelines to apply it in our hospital?
That's very important, because as we know, guidelines are based on international recommendations, but final decision, what goes in your hospital, is different from one hospital to another. So you need to take all the local guidelines or international guidelines and team it up and review it according to your local situation and your local standards. You cannot apply the same system from China and Italy immediately. You need to study it. You could see what works for you and what's your national guidelines and what are the resources. You don't have air purified positive pressure BBE. So you need to find other solution. Plastic bags, a combination of this and that, face shield, helmet. Today they're using even scuba diving equipment for non-invasive ventilation in Italy. This is never heard of, but that's a possible situation. Keep the infection control with you during COVID. You need the same infection control during COVID simulation is as important as infection control during real life. So the same standards for healthcare, you need to maintain the same standard on the equipment. So the equipment has to be aseptically clean, using appropriate solutions, and you need to use the same guidelines all the time. So whatever you do in simulation for antisepsis is similar to what we do in real life, and you have to how to transfer good habits from simulation to real life and from real life to simulation, because it all have to be as much similar as possible. But infection control, same. For example, we used to do courses with 25 and 30 people. Nowadays, all our courses maximum 15, 16 people. It depends on the space. Everybody has to be 1 meter away, and you saw that in the pictures. It's different than the other non-COVID time. So the same standard during simulation for infection control like real life.
Perfect. Thank you for sharing, Dr. Abdulaziz. I think we can conclude our lecture today. There were a couple of questions. If you do have another questions, please send it to the info email, or you can send Twitter account, and we're going to do another webinar to cover all those important questions. This is going to be the start for our webinar, and we're going to continue. And we would thank Dr. Abdullah Al-Marshad. He's the head of the scientific committee and the educational committee in our website. Before we conclude, I want to share with you two things. The first one, our website, you can see also the COVID-19 material. So if we can go to the website, I will go to it now so everybody can see it. So if you go to the website, you will find there is SSH COVID-19 update. And when you click on it, you will find the link which go to SSH, and you can find see all the information that Dr. Boker mentioned it. And you can find it also another way. If you go in the library, you can find it ahead. So in the drop list. So as you can see, there is any update seminars or lectures. And if you go down, you will find also materials. The other way around, you can go in the library and you can find it in the drop list in the library. So in the library, there is a book. And there is also, in the future, there will be articles and the COVID-19. The second thing that I want to announce that next week, Sunday, we will have another webinar. And this webinar is going to be run by Dr. Tariq Hazwani. He is a PICU consultant. He will talk about something which is similar to what Dr. Abdulaziz Boker talked about, education about COVID-19. What he's going to do is going to talk about his experience in COVID-19 sim drill and program. It's going to be around like today from 6:30 to 7:15 or 7:30. Like we did in the previous webinar, we're going to send you an email, which is you can register, and then we're going to send you the link so you can enter to our webinar. If you do have any suggestion or any suggestion of the topic or suggestion of the webinar, please send it to us. It's for you, and we get benefit. We learn from each other. So as Dr. Abdulaziz Boker said, this is a safe environment. We're doing it for everybody to get experience and learn, and we appreciate your presence.